Good evening, ladies and gentlemen. Welcome to Toward a Quality of Life here in the month of March in the city of Boston. And I'm proud to have with me, I should say in the year 2003 as well, I'm proud to have with me Dr. David Himmelstein of Cambridge Hospital, where he is a primary care physician for the past 21 years, all that time at Cambridge Hospital, for the past 21 years treating adults, and also a teacher at Harvard Medical School in internal medicine. At the same time, Dr. Himmelstein is the founder of Physicians for National Health Care, and that is going to be part of our greater subject this evening. I wanted Dr. Himmelstein and myself to talk to you about the problems with HMO, why we don't want to have a system of health care, and that's using the term loosely to be sure, a system of health care managed by HMOs, but rather we want to have a single payer or a national health care system, a government-sponsored system. Yes, we said that dirty word or words, government-sponsored, and try to get our brains and heads screwed on straight so that we understand this and know what's best for us. Welcome, Dr. Himmelstein.
Thanks for having me.
You're welcome. I'd like to start with what it is about HMOs that may not be in people's best interest, because you know every time you hear something about health insurance, you hear people say, oh, we don't want national health care, HMOs are the way to go, and right now the Congress is talking a lot about how to incorporate HMOs more into the health care system. What's wrong with HMOs, if anything?
Well, HMOs make money when they deny their patients care. Basically, you pay them a premium, and anything they don't spend on your care, they keep. And that means the million-dollar salaries for their executives. It means the ads on TV. It means the paperwork that they inflict on doctors and patients. All of that is a tremendous waste of resources, and it's a waste of our money, which is going against our interest. And basically, the less they spend, the happier they are with it. And that's a conflict of interest, which is a pretty fundamental conflict of interest. And we've seen that played out around this country when they were telling pregnant women they had to get out of the hospital right away after they delivered a baby, whether they were ready to or not. They deny psychiatric patients the care they need on a routine basis. They're often telling people who need transplants, no, we're not going to pay for it, or we're not going to give you the home care that you need to recover from an illness, because that's the patient's problem, not the HMO's problem in most cases. And they stand to gain financially from the patient's loss.
In other words, when an HMO really has to watch the bottom line.
Well, they watch the bottom line, and many of them do very well by watching the bottom line. So the heads of HMOs routinely make $1 million or more, some of them tens of millions of dollars as executives in those plans. And the reason they're doing that is if they please shareholders by making profits for investors, they make a huge profit themselves.
Right, and are they even essential to the healthcare system, these layers of executives that exist in HMOs? Is that a necessary part of a healthcare system?
Well, most countries in the world don't have that as part of their healthcare system, and most countries in the world have much less bureaucracy than we do. If you look, for instance, at the Canadian National Health Insurance System, they have about 1/10 of the bureaucracy of our typical private insurer. More people run Blue Cross Blue Shield in the state of Massachusetts than it takes to run the entire Canadian National Health Insurance System, which covers 10 times as many people as Blue Cross does. So there's a huge amount of useless bureaucracy in our insurance system, and those middlemen are really ripping us all off.
So in other words, they get to control the dollars that are out there being used, being thrown towards health care wherever it's ending up. In other words, there's a certain amount of money in the economy as an aggregate that is available by force or by necessity or by laissez-faire, just the way it's out there, and they get a grip on it, and they get to divide it up in ways other than delivering the most possible dollars towards health care.
Right. So for every dollar that you pay to an HMO, you only get about 85 cents worth of care out of it. The other 15 cents goes to pay the executives at the HMO, to pay the investors in the HMO for their paperwork and for their bureaucracy. And our Medicare program runs for only 3 cents on the dollar overhead. So for every dollar we spend on Medicare, we get 97 cents worth of care. Canada does even a little better than that. They get 99 cents worth of care for each dollar they spend.
Well, I think the lore and the common theme that is out there about HMOs is that they're somehow saving us money and saving the government money. Isn't that the kind of thinking we tend to have about it, or that's put out there?
Well, that's what they want us to believe, and that's what President Bush has been claiming. There's not actually any significant evidence for that. In fact, HMOs in Medicare have been costlier than the traditional Medicare program. So not only haven't they saved money, they've actually increased Medicare's cost. That's according to the Republican-controlled Congressional Budget Office. They cost Medicare $2 billion a year extra over what it would cost if there were no HMOs in the Medicare program. And they've actually been worse at cost containment than Medicare, as an example. The studies have recently come out that private insurers have cost about 40% more over the long run than Medicare in terms of the cost per patient insured.
Okay, so if somehow the HMO gets to handle Medicare, and that's a trend that's been happening, they get to have the Medicare dollars under their supervision or control.
Right, the president is desperate to give them our Medicare dollars.
Right, he's really trying to make it a total package now.
Yep.
But several of them have made inroads to control those dollars, right?
Right.
They have. And so you're saying once they get their hands on the Medicare and they're dishing it out and they're the ones, middlemen, providing service, so to speak, to people, the costs go up by latest Republican report on how this works.
Right. I mean, and the way the reason costs go up is pretty simple. HMOs get a fixed amount from the Medicare program for each patient whom they sign up. And they've signed up mainly very healthy patients who wouldn't cost Medicare much at all if they stayed in the regular Medicare program. Remember that among seniors, about 18% of all seniors cost Medicare nothing in the course of a year because they don't have any medical bills at all that Medicare has to pay. If you sign up one of those people in the Boston area, you get about $7,000 a year as an HMO, and you keep all of that money. And in fact, what HMOs have done is they've had very sophisticated marketing schemes to go out and try and get healthy seniors to sign up and to try and avoid sick people who would actually cost them a lot of money. Or if you do get sick in an HMO, to make it that you'd want to leave, and therefore they don't have to pay bills for you for long because you'd be unsatisfied with their care and you'd leave the HMO. So there's been this migration back to Medicare of sick people and into the HMOs of healthy people, and that's a profit strategy that they've had. Where it hasn't worked, they've done something even simpler than that, and they've said, we're not making enough profit in this town, we're just going to leave and close up shop here and dump all of our unprofitable patients
that has
back on
quite
Medicare.
A bit.
So millions of seniors around the country have been dumped from HMOs because they weren't profitable.
Right, and that ends up costing basic Medicare more money too, because if they're getting all the healthy people and the dollars for those, then the money left, the percentage of it that's got to go out, if the government is left with the more sick people, then they have to put out more than would be distributed if they had all the people, some not so sick and some sick.
Right. It's like saying we're going to run a car insurance system and all the drunk drivers get government insurance and all the safe drivers get private insurance, and we're going to have those premiums go to the private insurance companies, but the government gets to pay for the high-risk people. And that's essentially the system George Bush is pushing.
Oh, really?
Well, that government should contract with with private HMOs who would serve as the middlemen for the patients whom they wanted to attract.
How do they manage to single out or exclude effectively people that aren't sick besides, well, let's talk first about how do they not give them care when they might desperately need it?
Well, there are a number of ways. One is, for instance, for psychiatric care, they just refuse to approve it, say it's not necessary, we're not going to approve it. They're happy to approve relatively inexpensive drug treatment, but if you want to see a psychiatrist or psychologist for talk therapy, which we know is very useful and effective for many kinds of problems, that's much harder to get them to approve. And
do their plans say they will approve that, and then they end up not approving it?
Well, what their plans say is if you read the fine print that you are entitled to so many visits, but the fine print says you have to get their approval to get those visits paid for. And they often then just refuse to approve it. I think a second way is that we've seen, for instance, for patients who've had a stroke in the Medicare program, that's an expensive illness. Well, if they end up in a nursing home because of the stroke, the HMO is not required to pay for the cost of the nursing home under their contract with Medicare. And what's happened is that HMOs don't pay for the rehabilitation care that would be needed to keep people out of nursing homes. And as a result, HMO patients who have strokes are much more likely to end up in a nursing home. HMO doesn't have to pay for that care. Patient is dissatisfied, leaves the HMO, and the federal government Medicare program ends up paying for them. They also have been very skilled at attracting healthy patients and avoiding sick patients signing up in the first place. So, for instance, they run sign-up dinners at restaurants at night where there's no public transportation. Well, who among seniors is going to be able to get to those things? Not someone who's got major heart problems or blindness
or in a wheelchair.
Or in a wheelchair. You have to be someone who can get out at night and drive. And those are generally healthier than average people. In extreme cases, we've even seen things like sign-up offices up on the third floor of a walk-up building. And obviously someone who's crippled is not going to be able to get up to those sign-up offices. So there is a whole science to how you sign up healthy patients and you avoid sick patients, and the HMOs have that science down pat.
Now, let me get this straight. If someone has an HMO and they need to enter a nursing home for rehabilitative care, it will be in the contract that they should get that care, but then they end up not getting it from the HMO?
No, actually, under the Medicare program, the HMO is not required to cover nursing home care.
There we go.
If you need physical therapy at a rehab hospital to keep you from going into a nursing home, the HMOs are just not giving that physical therapy, that rehab care that would keep patients out of the nursing home and get them home. We know also that there's a lot of judgment as to how much home care someone actually needs, for instance, after they've had a stroke or a serious illness. And what's been found is that HMOs just don't approve as many visits for those home care providers as traditional Medicare does. And when that's been studied, what's been found is the patients actually do worse because of it. It's not that they're turning down extra things that aren't needed. They're turning down things that the patients actually need. And as a result, once the home care is over, the patients can't do the basic things for themselves, like bathing themselves and getting out of bed themselves, getting up from a chair themselves, the things you need to live independently. And as a result, those patients end up going into nursing homes. The HMO doesn't mind if they go into a nursing home because the HMO doesn't pay for it.
Right, and they don't mind, and also because they've become sickly. And this puts them in a different category already. So now they'd rather have them in a nursing home, maybe.
Right.
Right.
So we know the pattern is that HMOs are good while you're healthy. And if you get sick...
But wait, let's not say that, because they're not good then.
Well,
what good is good? I know. What good is good?
That's exactly my point, is
words,
that they're good medical care as long as you don't actually need them.
Yeah.
And unfortunately, all of us eventually are sick and need help. and at that point your HMO turns out not to be so good.
So what you're saying, in effect, is that they're not good medical care, period.
I think that's clear.
Yeah, I would agree with you there. Okay. You know, also listening to you talk regarding the denials of care and some of the ploys of how to work around really unhealthy people, I'm thinking also of how quick and minimal care is, if you really want to call it care now. The time you get to see a physician, the number of visits allowed, or a psychologist or a psychiatrist, and how narrow the time is and how fast it has to be accomplished. I, like yourself, come from a generation that can remember that when you had something wrong, you may wait quite a while in a waiting room. You'd sit there, you'd relax, you'd wait. The physician would be there. You'd say, "Oh, doctor," you know, you'd have time to say that, and you know, you'd come out feeling satisfied that you know, you had a communication and that something was accomplished. And then the next day, if something still wasn't right, you had the opportunity to go back again and see that same physician. Now, it's like put you on a chair that spins and you just go, bye, bye. It seems like, did I see the doctor or not?
Yeah. Well, I think healthcare has become much more of a business, and the language of business and the pressures of business have come into play. So we hear more and more about productivity, and are you seeing enough patients per hour to
patients per hour?
to
Can you
actually
imagine?
justify the hospital or the clinic giving you the space to see those patients. And obviously that erodes the relationship between the doctor and the patient. It makes the patient into a commodity, and commodities don't get treated right.
Yes. How many patients does a physician see in an hour? I know different specialties would be different, but...
Well, the average visit in this country at this point is about 15, 18 minutes, something like that.
Oh, that long? It seems shorter.
Well,
when you actually go on one, it seems shorter.
Remember, that includes psychiatrists and who are averaging longer than that, and so that's all thrown in together. But of that 15 or 18 minutes, the doctor is also including in that the paperwork they have to do, which often at this point takes up a third of the visit. So the actual time a patient gets to talk to a doctor probably is about 10 minutes.
That's pretty high. I've seen it even seem less than that, really. Some of it, you know. Yeah, I guess 10 minutes is probably...
10 minutes can go pretty quickly, but...
I've seen what looks to me like 5-minute neurological exams.
Oh, I think that's clearly going on.
You know, and talking, so saying something else while you're doing the exam, you know.
Well, 1 hour-long visit would jack that average up quite a bit. So 1 hour-long visits and a bunch of 5-minute visits equals a 10-minute talk with a patient on average.
Now, what about fees? It seems to me fees are getting curbed, too, with HMOs. Fees, reimbursements to physicians and...
Well, there's a continual fight between doctors and HMOs about what's the appropriate fee. I guess my own view is that doctors at this point are well paid, and that's not my biggest complaint about HMOs. I think that if we could spend more time with patients and get business out of the middle of our profession, there would not be such big complaints about what we actually make. The average doctor is making a good living.
That's true, but if you look at it in the context of a culture that pays phenomenal money to lawyers and accountants and computer specialists, and not that one wants to go for the money, but if you look at what it takes to become a medical doctor, and it's not as much as it used to be in a way, but still, you know, the best of the best used to be, I know there's not as many coming forward today. It takes quite a bit of brain power to do a medical education. Yeah. So if you look at it in terms of parity, you know, with what other people are getting paid, I think it's really poor.
Well, I guess, you know, you can look up and you can look down, and my view is compared to some of the folks I work with at the hospital who work hard and don't make much money, I'm well paid. I think it's criminal what some of the people in this society are getting paid today, and we ought to bring those people down. So when we see that there are HMO executives making $10 million, I don't think that means I ought to be up in their stratosphere.
No, but wouldn't you, even though it might not be a cause of yours, just theoretically, if you see someone who's an administrator making that kind of money, and you've been to medical school, and you have the malpractice insurance, and you have the boards to pass, and you have the education to keep up with, and you have all the liability, and you have all that draining work every day, doesn't it seem out of balance? It is out of balance.
Oh, I think there's no question it's out of balance. But my own feeling is doctors make enough. It's that there are some...
That the others have to be
some others
much
in the
more
society.
leveled off.
Yeah.
Much more leveled off.
Yeah, we've had a tremendous increase in inequality in our society with a few people at the top making ridiculous incomes.
I know, but doctors have really had their heads chopped off, so to speak, relatively speaking. If you're not looking in absolute numbers, but in relative numbers, it's amazing. I mean, how much is a brain surgeon worth? A guy who can go into the brain and do a successful surgery.
Yeah.
If you're going to value it by looking around at what other people get paid to do certain things, you know, to tell that physician whether he can do the operation or not.
I think most of us in medicine, if we could actually get back to a humane medical system and not be burdened with the kind of bureaucracy, paperwork, and restrictions that we face, if we could spend the time we need with patients and get back to having it be a calling, wouldn't find our incomes the problem.
Well, you see, like in psychology, what bothers me is the fees that are obtained are only through, and for physicians too, are only through the work of the individual that has made that happen, and then people come in and they're taking most of it. They're lopping off, you know, huge chunks of that money. For what purpose? And that brings me to the next part. Who's the boss? You know, this is absurd. Not only in terms of reimbursement, but decision making and authority. Not authority like I have to be the one in charge, but common sense authority.
Yeah. Well, I mean, what we've got is a healthcare system with business people in charge, and that's a huge problem. We ought to have a healthcare system with patients in charge.
We ought to have a healthcare system with physicians in charge of what they want to think and say and do with the patient in cooperation with what the patient wants to do.
And the patient in charge of their own lives and their own participation in the healthcare system, not at the mercy of some business people.
But wouldn't you say that physicians should have much more of their own natural right authority to decide if surgery should be had or not, what rehab services should be had, which medicines should be given or not, you know, as the sole end?
I think that we need to take away the business people overseeing physicians' work. I think it's also true that doctors have made a lot of mistakes in the past, and we need to admit that doctors have been greedy and have often done things that aren't so good as well. So there's been a lot of unnecessary surgery in this country because doctors took advantage that you made more money by doing an operation than you did by not doing an operation. So there needs to be accountability of doctors as well. But the kind of system we have now is not accountability. The kind of system we have now is business people trying to squeeze the profits out of healthcare on their own, for their own interest.
Yes, and although physicians will take advantage, as you know, people do, the buck has to end somewhere, and it shouldn't be in the hands of people that know nothing about, that haven't.
Absolutely.
Yeah, this is absurd.
Right.
Absurd, and I don't know how did it get to be that way. Did I know with psychologists, no one ever spoke out, and it just got worse and worse, and no one ever said a word.
Well, I think some doctors have spoken out, but we've had poor leadership, and I think the other thing is we've faced tremendous power in the HMO industry, in the insurance industry, in the drug industry, in the corporations that make money from our system. And they've shaped healthcare so that they can make their money out of it.
What about the paperwork you mentioned lots of paperwork. What kind of paperwork is there?
Well, the insurance companies inflict huge amount of paperwork throughout the system. My group practice, we spend 10% of our gross receipts on a billing service just to put together our bills to send them to the insurance company, because the insurance industry has hundreds of rules and regulations that we have to comply with, so that we're spending huge amounts of money just to make sure that the bills are filled out the way they demand they be filled out. And huge amounts of my time spent complying with their rules and regulations. It's become a game of mother may I. Every time I want to order a test for a patient, I have to get the insurance companies, the HMO's permission to do that, get on the phone, get the approval from them to refer a patient to a specialist, to get an MRI, to prescribe a particular drug, to do what needs to be done for those patients. So it's both very complex, and they've got a huge number of rules and regulations that take up a tremendous amount of the doctor's time. And the same thing for hospitals. The average American hospital spends about 1/4 of its total budget on its administration. And we know we don't have to spend that much. Canada spends only half as much on administering hospitals as we do.
I'm thinking of authorizations that I have to get. Not only is there an awful lot of paperwork, and that has taken the beauty, the glory, the wonderfulness of clinical care out of daily existence. It's really ruined that specialness of it. And many people will echo this sentiment. And nurses will echo that sentiment, and it's made us just labor at paper instead of labor with people.
That's absolutely right. And in hospitals, nurses spend half their time documenting for the insurance companies what's been done, and that takes away time that they can actually spend with the patient. So we've got this flow of resources to deal with the paperwork and away from actually the humane side of caring.
Yeah, so there's less clinical care. There's less care going on in and of itself, just for that reason, because there's more being done with paperwork.
Absolutely, and huge numbers of people employed just to push papers. So the average hospital has probably 50 to 100 people doing nothing but it's billing, which is unnecessary stuff. The average Canadian hospital has 1/10 that number.
And not only that, the folly of what the paperwork entails, like if I get an authorization, this is too stupid to be real, but it's real. I get a long authorization number. So after waiting a long time on the telephone and telling all this rote stuff over again that I might have had to say before, that's already probably on their computer as they're listening to me, then they come back, finally, after a long amount of wasted time, totally wasted time, they'll come back with a number, 0908001825357901. That'll be my authorization number.
Yeah.
And I have to keep a record of it, and I have to make sure that's available in the billing.
Yeah.
And the number of authorizations will be very few, like 3, even though the person is very ill and needs, at least 15, 20 sessions most likely. And so I'm going to have to go through this each time with a new authorization number and wait on the phone. And
Right. Well, it's a kind of rationing by inconvenience. They're hoping people will just give up and not make them
some
pay
days
for
they're
care.
not available on the phone.
Yeah. And they have all kinds of tricks. For my own family, they decided out of the blue they wanted to change my daughter's insurance number, the number of her membership ID number. And when she went to the pediatrician, they didn't pay the bill. We tried to figure out why, and it took us 3 months to figure out, the insurance company decided they changed her number so that when the pediatrician sent in the bill, the insurance company said, we don't know this person, you've sent us the wrong number. So they avoided paying the bill for months. And you might say, well, what good does that do to the insurance company? it does good for them in a couple of ways. One is some people give up and just go ahead and pay the bill themselves. But the other is they've got the money for themselves over that 3 months, and they can invest it and earn the interest on it. And they earn billions of dollars each year on that interest until they pay the bills.
Who came up with the idea to have health care in private hands like this? Remember, it used to be a fee-for-service system. We used to have Blue Cross Blue Shield was a major insurer, as was Aetna, I believe. But it was a fee-for-service. You went to any doctor you wanted. You got the service. You had the length of time you needed to spend with the person. And, nobody got in the way. And the bills got paid. It wasn't there was no authorization and, middlemen. How did it get that people came in on health care and grabbed hold of it?
Well, it's actually under Richard Nixon that the HMO system got its start. And if you're as old as me, you remember back to that time when it looked like we might actually get national health insurance in this country in 1971, 72. And Nixon needed an alternative to what should be done about health care instead of national health insurance. And he put forward the HMO system as the alternate plan to national health insurance that Ted Kennedy was pushing at that time. And he said that's going to solve the crisis in our healthcare system, is to put these HMOs in charge and reform the system along that line. So that's really the origins, is about 30 years ago, the passage of what was called the HMO Act. And actually, it was Nixon's people that coined the term HMO. Before that, it was an unknown word, and they said, we need a good-sounding name for these things we're going to start up, and Health Maintenance Organization sounded pretty good to them, much better than, hand the money over or any of the other things that HMO might stand for.
Some words you don't want to say, huh?
Yeah.
What was so bad about the healthcare system that it needed to be intervened on?
Well, at that point, costs were going up fast. More and more people were losing their coverage because they couldn't afford it. And there were complaints that quality was a problem. And now we have 30 years later, costs are going up faster than ever. We have more people uninsured by far than were uninsured in 1971. And the Institute of Medicine tells us that our quality problems aren't being addressed. So HMOs were supposed to solve those things, and if anything, they made them worse.
I can't believe people supposedly say, according to polls, that they're satisfied with their health care. I can't believe that. If we are satisfied with our health care, I don't know where we're going to visit.
Well, healthy people are satisfied with their health care.
Is that who's saying
so
that?
if you think about it, only a few people are sick each year. And if you actually ask them if they're satisfied with their health care, a lot of them say no. But people who have done nothing but go to visit their doctor once a year and get a routine checkup, they're often satisfied with their care. It's only when you're sick that you discover the healthcare system isn't working. And that's part of the problem, is it's only a few people who discover that each year. Now, in fact, more and more people are dissatisfied with our healthcare system, and we know that there's rising dissatisfaction. And for that reason, there's going to be a big debate about what should be done about it, if for no other reason that more and more people are being priced out of care.
And another trend, too, more and more paraprofessionals doing medical jobs, interfacing with people and answering questions or performing minor parts of the medical care.
Yeah, and some of that is good and some of that is bad, and the problem is that there's no rationality to using people in roles where they're adding value to the system, but not just in those where they're adding profit to the system. So there are many nurse practitioners who are highly skilled and do a superb job, and we ought to use them where they're in fact very useful. And there are other folks who are being pushed into roles that they're not qualified for, even in many cases doctors being pushed into roles they're not qualified for. We know that many primary care doctors are being pushed to provide specialty care that they don't feel comfortable giving.
Why is that? To keep costs down again? or-
Because HMOs don't want you to refer to specialists who tend to be more expensive, so that in many cases primary care doctors are being told, no, you take care of the patient with quite serious heart disease, don't send them to the cardiology specialist. So that's not to say that primary care doctors don't have an important role in the system. I'm one, and I think clearly they do, or that nurse practitioners or other paraprofessionals or professionals of different categories don't have important roles in the system, but they should be appropriate roles, not the inappropriate roles.
Mm-hmm. But there's so many times when really you really want to know the kinds of advice all the different layers can give you definitely vary according to education and experience, and so often you really want to know what the doctor has to say about it and what the doctor thinks about it.
Absolutely.
There's a big difference.
Absolutely.
Explain to us about capitation. What does that mean? That's something that HMOs have as a practice.
Well, HMOs discovered about 10 years ago that doctors respond better to bribes than to threats. So they'd been trying to get us to go along with what they wanted by saying, if you don't deny care, we're going to hassle you and we're going to throw you out of our plan and all kinds of other things. And about 10 or 12 years ago, some of the HMOs started to discover that if they offered us a piece of their profits, essentially, then some doctors would jack up those profits. And what that means is they say to the doctor, for every dollar in specialty care that you approve of for your patients, 50 cents of that comes out of your pocket. For every dollar in more expensive tests that you order, a certain amount of that, maybe 25 cents, comes out of your pocket. And what that means is that the more tests you order as a primary care doctor, the less money you make at the end of the year. The more patients you send on to see a specialist, the more comes out of your pocket, the less you make. And the more the HMO makes in profit. So it's been a very profitable arrangement for the HMOs, but it really sets doctors' interests at odds with their patients and is, I think, a clear conflict of interest. I think it ought to be illegal. We tell doctors, you can't make money by referring a patient to another doctor. That's called a fee splitting or a kickback arrangement, and that's against the law. But we don't tell doctors, you can't make more money when you refuse to refer a patient to another doctor. That's what HMOs are now routinely offering as a system for paying us, and that's perfectly legal but immoral. And we know most doctors don't like it. Most of us, if you ask us, about 80 to 90% of doctors say that ought to be against our code of conduct.
Not only that, healthcare and dollars just don't seem to go together, really. It's somewhat like rent, housing. It's like healthcare is healthcare. It requires a certain thing, not more, not less. The correct healthcare is just what it is. It's either it's what it is or it's not. There can't be like more of it or less of it. It's just what is needed, and it doesn't seem to go together at all with dollars. Cost benefit kind of. Even it's not even cost benefit. That's not a correct application. But healthcare, it just is. I mean, if you have a certain disease or a condition, and a certain thing will fix it, it will, whatever it costs. If it will do it, it'll do it, and that's it.
Yeah, and unfortunately, we've turned healthcare into a big business in this country and put money right in the middle of the exam room.
But it doesn't match with business. It's not like cookies or pencils, or it doesn't.
Right.
It doesn't match with.
These are human beings.
Yeah.
Human beings
it
are.
It doesn't match at all with the model. Now, who's going to pay for national health care? People, when you hear the words national health care, so many get a bad taste in their mouth, and most of what you'll see on a television is going to have a nasty flavor to it when those words are uttered. But how would that work, and who's going to pay? What's it going to cost?
Well, we're already paying for national health insurance. We have the most expensive health care of any country in the world by far. So just to give an example, Canada has national health insurance, but they spend about 40% less per person than we do on health care. Much of that difference is the savings in bureaucracy that they have because they don't have the insurance companies in the middle of their healthcare system. So our government is already spending more than the Canadian government on healthcare, but what they're doing is spending it in all kinds of irrational ways in an irrational system. Our Medicare program is throwing money away on HMOs, as we talked about. That's one way, but there are many other ways. Our state government workers, the firemen and policemen and teachers, are all getting private insurance paid for at government expense. That's a huge chunk of change, which is much of it going to the insurance companies and not going for the care of those government employees. So we're actually spending enough to give everybody in the United States good, comprehensive health insurance if we did the system right. And what that means is shifting the money from private insurance companies into a publicly insured fund that would allow you to go to any doctor, any hospital in the country, as Medicare now does. And it's, in essence, we're talking about Medicare, but an improved and upgraded Medicare system that would cover everyone. Medicare is already the most popular health insurance program in our country. Medicare patients are more satisfied than Blue Cross patients or Harvard Pilgrim patients or private insurance patients.
It's old reliable. It's good old reliable.
But Medicare doesn't cover enough. Medicare doesn't cover drugs for its patients. Medicare doesn't cover the first day in the hospital for its patients. So we need to upgrade Medicare, but it provides a reasonable first-pass model of what national health insurance might be. And we know that Medicare is more efficient than private insurance, and that if we spread Medicare and upgraded and improved Medicare to the whole population, we could afford it. It would mean taking money that we now pay as insurance premiums and instead paying them as Medicare premiums. So there would be that change. But relabeling money that we're already paying is not actually paying more. For wealthy people, it would probably mean a slight increase in what they're paying. For poor people, it would mean a decrease in what they're paying. But overall, the American people needn't pay any more to have coverage for everyone, for everything.
So pretty much the way the tax system is set up for Medicare now would be the means by which this would be funded.
Well, you'd need to collect money as taxes, and Medicare collects it with a particular tax, and there are a variety of taxes you could use to collect the added money. You could say that rich people are going to pay more, which they don't now for Medicare. It's 7% of the first $70,000 in income goes for Medicare. You could say that when you get over $500,000, you start paying higher tax rate. Personally, I think that would be fairer. But what we would say is that the money ought to be collected in taxes as Social Security or Medicare is collected in taxes, and then paid out to doctors and hospitals and psychologists and nursing homes and all of the organizations that provide care in this country. We're not talking about government medicine. We're talking about private medicine with a social insurance fund that pays to those private providers. In fact, Canadians have that kind of system, and Canadians have a wider choice of doctors than we have in this country. People in Canada can go to any doctor in Canada, and most people in the United States have a limited choice of doctors whom they're allowed to go to, that their insurance plan says, okay, here's the list of doctors you can go to. Most of us have a limited range of hospitals that we have to choose from. Canadians can go to any hospital in that country. So, in fact, we're talking about wider choice, increased choice. We're talking about less intervention. Our Medicare program hassles doctors and hospitals much less than the HMOs do, and much less bureaucracy. And we're talking about no higher costs. The big problem, of course, is that most of the extra money to provide care comes from saying to insurance companies, we're not going to pay your outrageous executives' incomes. We're not going to pay for the advertising on TV that you do. We're not going to pay for the fancy offices that you occupy. And we're not going to pay for the bureaucracy that you make doctors and hospitals put up with. It means saying to the drug companies, we're not going to make you the most profitable companies in America as you've been for the last 10 years. We're not going to pay $20 million to your executives. We're going to say to you, we're going to do some hard bargaining about what you charge for your drugs. Canadians buy drugs from our drug companies, but they pay 40% less for them because their government does hard bargaining with our drug companies. If our government did that kind of bargaining, we could cut drug costs easily by 40%.
Does this mean the decision-making of what should happen in a person's care plan would be up to the physician or up to medical care specialists?
I think it clearly means transferring the decision-making back to the patient and the doctor. It also means more in the way of quality oversight. So if there's a doctor who's doing lots of unnecessary surgery, they need to be stopped, and we need to have strengthening of oversight for quality, but not for quantity of care, not saying you're doing 3 visits too many to talk to that patient. But what we need to do is say, is there a surgeon who's having a lot of patients dying on the operating table? That surgeon, we ought to be reviewing their care and saying, are they actually creating a problem with quality?
Who would be the oversight?
Well, we have state medical boards doing that kind of thing now, but doing it with pitifully little in the way of resources. So we've heard a lot about the malpractice crisis. We've heard relatively little about the hundreds of doctors who've had 5, 6, 7 malpractice cases that they've lost, and the medical board hasn't had the resources to say, hey, what's the problem here that this doctor is not just being sued once or twice, that can happen to any of us, but being sued 5, 6, 7 times. There are doctors who've taken off the wrong leg, and the medical board has never looked into what's the problem that that doctor is practicing substandard medicine on a routine basis. So we need to both strengthen that quality oversight, but not have it be an organization that makes money by denying care.
Yeah, some boards go overboard in following cases of complaints. On the other hand, there's excesses in both directions.
Oh, I'm sure there are.
Yeah, definitely. Fee for service. Would medical care personnel be paid a salary, or would they be paid by visits? How would that work?
Well, what we've suggested is that there be really 2 options for how people could be paid, and the doctor could decide how they wanted to work. There would be fee for service available for doctors and patients, or doctors could work on a salaried system as part of a large organization. So, for instance, I work at Cambridge Hospital, and my preference would be to work on a salary at that hospital, and that would be one of the options available.
Would they then say how many patients you should see?
I would negotiate that presumably with the hospital.
Yeah, you'd have to negotiate that, how much you'd do for your salary. I think in the past they never looked at things like that, like how many patients, you just had a visit was a certain length of time, and you'd fill up your book, and that was it. You never counted, to be sure, which was a nice way of doing things. But you say Canada, and that's another word with health insurance that doesn't sit well, or England.
Yeah.
People think these are bad. They've been told they're very bad.
Yeah. Well, our insurance companies have spent hundreds of millions of dollars pushing lies and distortions about medical care in other countries. There are problems in Canada, but they're very different than most of what we hear about. In fact, Canadians get more care than we do in this country. They visit the doctor more often than we do. They stay in the hospital longer than we do. They're not rushed out in the way that we are. They live longer than we do. Their death rates are lower. Their infant mortality rates are lower. There are a few high-tech procedures they probably don't get enough of. That's because they spend so much less than we do on medical care. As I said, they spend about 40% less per person than we do on their healthcare system. But if you had a Canadian system with the amount we now spend, we could have our cake and eat it too. We could have far and away the best quality care in the world. I mean, looking back at the end of World War II, America had pretty much the lowest infant mortality rate in the world. And we're now 23rd from best on infant mortality, and we trail most of the developed countries in Europe and Japan, Australia, Canada, in both infant mortality and how long we live. And yet our insurance companies have tried to convince America that they're getting the best care that anyone in the world is. That's just a lie. In fact, Americans are often denied care they need and often aren't getting the highest quality care that they ought to get. So on balance, it's pretty clear that Canada's system works better than ours, even though they spend less. If we took their system and put more money into it, they would have far better care than they even do.
Now, another word that gets bandied is single payer. Explain exactly what that means.
Well, what it really is national health insurance that I've been talking about. Part of the reason that other countries have been able to eliminate a lot of the bureaucracy is they have this kind of single payer system. So in our system, a hospital has to keep track of who got every Band-Aid and aspirin tablet. And we have to justify that to the insurance company one by one. And that's a tremendously inefficient way of running a hospital billing operation. A Canadian hospital, now just to go back, my hospital administrator knows January 1st what our hospital budget will be for the entire year, but we arrive at it piecemeal. We get a penny for each Band-Aid, and we have to send out hundreds of thousands of bills to get our budget. A Canadian hospital negotiates its budget with the provincial health insurance plan at the beginning of the year, and they get one check a month to cover their entire budget. They don't bill for each Band-Aid or aspirin tablet. Their administrator knows January 1st what their budget is going to be, just like mine does, but they have a much simpler way of getting paid for it. That's a huge savings. You can only do that if there's only one organization that's paying for the care in that hospital. And that's what they have in Canada, is the national health insurance system that pays for everybody's care and negotiates what running the hospital costs. That's the way we run a fire department. We don't say to a fire company, bill us for the gas for each call. We don't say to them, we want you to bill us for each sandwich that the firemen ate while they were on duty. What we say to them is, we're going to negotiate with you what your budget for the year is going to be, and you provide fire protection for the people who need it in this community. That's the way a Canadian hospital runs. They negotiate what their budget is going to be, and they provide for the services of the people in their community who need their care. It eliminates huge amounts of bureaucracy, but you can only do it if you've got one organization paying for care. That's the single payer. In fire, it's the single payer paying for the fire company's operations. It ought to be that way with health care.
So in this case, it's the government paying, and the money that they're paying is money that comes from taxpayers, and no matter which way you look at it, you have to pay some money if you want to get health care, whether it goes to taxes or it goes directly to an HMO.
Right.
You have to pay money, and so...
And we all are paying huge amounts now.
Oh, and we know the rate of inflation on health care is what, 4% now? 3%? Every year.
I wish it were only 4%.
Seven,
it's up to 7, 8, 9% now.
It keeps on being the one big inflator every time those indices are shown. Well, this about concludes our talk today with Dr. Himmelstein on, again, national spokesperson and founder of Physicians for National Health Care. Hope you got a little enlightened as to what is in your best interest, according to how we've explained it. Sounds a bit socialistic. That's another bad word in the American dictionary.
Well, I don't know. You know, I guess if Canada is a communist country or a socialist country, if all of Europe are socialist countries at this point, then maybe it could be considered socialist. What I know it is better health care.
Okay. And if we're going to be anything, if we want to call ourselves a country, a nation, under a flag, etc., we certainly can be social, and we certainly can provide social insurance for all of us as a group, as a coherent whole, to get better service, especially on something that is so near and dear to our hearts. Thank you very much for listening, and
I